welcome everybody. My name is Gene Van Vliet. We will be missing George Johnson, who is usually the facilitator of our meetings. He and his wife made separate commitments, and obviously who won. So I want to welcome all of you, especially all you newcomers. If you are a newcomer and did not get a package of information, raise your hand so we can get one to you if you haven't been to the meeting before. This is the yellow form on top. And if you did get a package, please return that top questionnaire form to me by the end of the meeting, or sometime. Just bring them up here and lay them in the table or something. And I call each of you individually, because when we have a speaker, we often can't give you each all the attention that we'd like to. So I call each of you individually on Monday, and we'll talk over your particular situation, see if we can help you out. Now I'd like Lyle to come up and do a little presentation here.
You got my deal?
This.
There it is.
And there it is right there. Okay.
Okay. Good morning, everybody. Thanks for showing up in the rain. This is something that we don't normally do in this group, and certainly this is the first time for this particular event. And it's kind of a serious thing. Most of the time I stand up here and try to tell jokes. But the words commitment, dedication, and loyalty come into mind when I talked to you this morning. And in volunteer groups such as this, those three words really make this group hold together. Some 19 years ago, the history fades into myth and legend, but two guys started this group, and one of the first guys that they recruited is someone that we're going to honor this morning. Now, if you make a commitment to something and it lasts for 20 years, that's really saying a lot. To show up every morning, Saturday morning, third Saturday, haul the stuff in and haul it out, that is something that most people aren't willing to do, to make the commitment in that regard. So I'd like to call my buddy Bob Keck up here right now. Robert. Bob, he's going to say a few words, but I'm just going to tell you, he was here when I got here. Everybody thinks I founded this thing. I didn't. I just kicked it and moved it along a little bit. But Bob was here when I got here. So today we're presenting him the typical, we don't have a gold watch. We didn't have that much money. But we do have a plaque here that says, presented to Bob Keck for over 20 years of service as a librarian for the Informed Prostate Cancer Support Group.
Well, thank you, Lyle.
Let me give you the next one.
What? Something else?
This is something he can put on his desk. I don't know if he has a desk. Put it by his computer. But this is a nice crystal plaque in recognition of Bob. It says basically the same thing. Thanks for the memories, Bob Keck, for 20 years of service as the group librarian. And so with that, I would like to have a round of applause for my buddy, Bob Keck. Go ahead, Bob.
We just leave that there for a while?
Sure. Well, why don't you say a few words and then you can go sit down.
Go ahead.
Well, don't be long-winded.
I don't know what to say. 20 so years ago, this group was just forming, and I can't even remember the name of the leader of that group. the speaker, but the founders were still there. And somebody said, we need to start a library. Our group doesn't have a library. So I put up my hand and gathered a lot of stuff and initiated it all and got it rolling, and also helped out another group that needed a librarian help and gave them help too. So I'm kind of a quiet-spoken guy, and I guess that's why I'm a good librarian. I don't know. I'm an ex-engineer, and I'm enjoying my retirement from my regular work, but I'll still be here to help out Bill as he needs it. Thank you very much, and thank you. Bye.
Sure.
Go take my water.
Okay, all right. Well, I think we're ready, and I just wanted to mention, especially for your newcomers, a couple of really good books available in the library. Speaking of libraries, Invasion of the Prostate Snatchers, I think I mentioned, and the Prostate Cancer Breakthroughs, written by Dr. Jay Cohen, who's a friend of many of us in this group. There's a lot of good basic information in these books for you guys. Also on the, we call it the freebie table outside, is brochures for a seminar coming up on June the 13th, promoted by Genesis Health Group, and it's called Promoting Wellness for Prostate Cancer. I think quite a few guys went to it last year, and the guy's name is in here. Frank Galis is the guy that will be speaking to us that I couldn't think of before, thanks to Lupron. The speakers include Don Fuller, who's spoken to our group, Frank Galis, who's spoken to our group, Christopher Kane, who is a urologist from USD, has spoken to our group, Dr. Kipper has spoken to our group, and I'm currently under his treatment doing Xofigo. And last but not least is Mark Moyad, who many of us are familiar with as the MC for the PCRI conference coming up in September, which just managed to lose. But it's always worth attending the national conference. And the more brochures on active surveillance from the prostate oncology specialists in Marina Del Rey, who are the doctors of many of us in this group. So just wanted to mention those things. And then it's already on there as who our speaker is. You've seen us fussing around trying to get his computer going. Fortunately, we've got it going, I think. So if we know how to connect it up again, please go ahead. I'll throw up here his background here, which I won't read to you. You can read it yourself about his background information. So go ahead.
Hi, my name is Ross Schwartzberg. I'm a radiologist here in town. My company is called Imaging Healthcare Specialists. We have 12 centers all around San Diego County. And I want to thank Gene and Lyle for...
You have 5.
This is microphone.
I wanted to thank you guys for inviting me, and thank all of you for coming and listening to my talk. This is going to be casual, and if you have questions, you feel free to ask. I'll stay at the end of the talk and answer anything you want to ask. I also want to congratulate you on this group. I can identify with a support group. This is a picture of me from April of 1970. Obviously, I'm in the hospital. You can see the era when nurses wore nice caps like that, which they don't wear anymore. So I had fairly severe childhood asthma, and I was in the hospital most of the time. And this is in Toledo, Ohio, or Ann Arbor, Michigan. We lived in Toledo, and we often went up to Ann Arbor, to the University of Michigan, for treatment. And I saw a lot of doctors, and I developed a distaste for the way I was treated as a stupid young kid. I was a young kid, but I wasn't stupid. And I became my kind of, over the years, my own advocate. In one little session, I was in the hospital. In those days, they would put the asthmatics in with the cystic fibrosis patients and with the hemophiliacs. And as you probably know, that hemophiliacs is a clotting problem, a bleeding problem. And one time, one of the boys complained of a headache, and the nurse came in with an aspirin. I said, "What the heck are you doing? You can't give a hemophiliac an aspirin." I really got after her. And that began my career as a patient advocate. So let's do a little thought experiment. And for a second, imagine that there's no way to see breasts, or rather breast cancer. You can't see breast cancer, you can't feel breast cancer, and all you have is a blood test, we'll call it BSA, breast-specific antigen. And you get it taken once a year, and if it's little high, you go in and the doctor says, we're gonna have to do a random 12 or 24 core biopsy of both of your breasts, and we'll see what it shows. It's about 30-40% of the time we might miss a cancer. Hopefully nothing will happen to you. We'll see you next year. On the other hand, if you do have a cancer, let's just whack it out. And of course, that's horrifying. I mean, nobody would stand for that. But truthfully, that's been the traditional paradigm, traditional clinical pathway for prostate cancer, and it leaves a lot to be desired. So Patrick Walsh is still professor emeritus at Hopkins, urologist, and he was a leading guy in urology, became extremely well known for nerve-sparing radical prostatectomy. And this is what he said at a talk a few years ago, that wouldn't it be great if we could see cancer in the prostate gland? And I'm here to tell you that I hope by the end of this talk that you'll agree that we can see it. And we can see cancer in the prostate gland. We have it right here in this community. And I'm hoping that you'll agree that it should be a part of the whole process of detecting, localizing, and deciding treatment for prostate cancer. So I'm going to start just with a few. These are real cases. Just get your thoughts on what you might do. So a young guy has a significant family history. So he starts getting PSAs a little earlier than maybe he would have. And they're a little high, they keep going up. So now Gene was talking about the molecular markers and the biomarkers we're discovering, not only for treatment, but for assessing risk of prostate cancer. So this is one from Michigan. I think they call it the May prostate panel. It's looking at several genes and the pathway that can lead to prostate cancer. So he gets that done, and he thinks, and it's higher than average, so he's at risk. So his urologist says, well, gee, let's do the biopsy. So this happens to be my best friend. He was my classmate of mine from medical school, best man at my wedding. So he calls me up. He says, what do you know about prostate MRI? I said, well, I know everything. So this is, I said, don't, please, either come down to see me or I'll tell you who to go see. He's up in Portland. Actually, nobody in Portland is doing it, but there's other places. I said, before you do anything, come see me. So this is our first image. We'll explain these images a little bit further as we go on. So this is looking at axial image. So imagine you're looking from the feet. So the central, do we have a pointer by any chance, Jane? Oh, okay. So this is the prostate gland here. These are the buttocks muscles, the pubic bones, pubic symphysis. This is the inguinal region. This is the anterior portion of the abdomen. And then so right there is the prostate. This is a basic sequence we do. And I'll just show you that there's just this kind of bilaterally, this kind of darker signal, kind of looks a little feathery throughout the gland. Now this is a coronal image, meaning cutting this way. So the patient, imagine you're looking at a person standing up. The bright signal, is the fluid in the bladder, the hip bones here, and then here's the prostate. You can see this darker area here, and then you've got all of this kind of intermediate striated stuff there throughout the rest of the gland. We'll talk about, again, these images much more so you understand what you're looking at. This is called an ADC map, and right signal in the bladder, kind of just scattered, bright signal kind of in the prostate, some lower signal areas throughout it. And this is the dynamic contrast enhanced. So this is where we inject through the vein contrast, and then we do rapid imaging through the prostate gland for about 5 minutes, and then send about 3,000 images through a software program and develop these parametric maps. And the different colors are showing you the concentration of contrast in the gland over a certain time period. So red means a lot of contrast, and enhancement of the gland diffusely. So now what? Well, this pattern is very good this is what prostatitis looks like. This does not look like cancer. There's nothing in this exam that of any concern that there is a significant cancer. So I said, listen, you've got prostatitis, which is probably why your PSA is up. There's no tumor suspicious lesion is the terminology we use when we read these studies. And if you want to get a biopsy, that's up to you, and this doesn't preclude that, but I don't think it's necessary. So the end of that story was he then got another 4K test. It's another one of these molecular tests you may have heard of, and that came back super low. And then his PSA is coming down. So I don't think he's got prostate cancer. So that was one little vignette. Here's another one, and this is a recent case. Well, so young guys with elevated PSAs going up over about 4 months. So what should we do? Well, there's, you could take some antibiotics and wait a little bit more. I think you might know what I would suggest since I'm here talking about it. But he goes and gets a biopsy. So this is a standard trust biopsy, which is the transrectal ultrasound guided biopsy. The ultrasound shows you the gland. It doesn't show you anything else about the gland. It doesn't show you, normal gland versus tumor. And he comes back with 1 out of 12 cores positive for Gleason 3+3, the 10% of the core in the right apex. So now what? So his doctor suggested he get a prostatectomy. Gene discussed active surveillance, which, and we'll talk about more of that. The main issue with prostate cancer is the incidence is high, but the number of patients that have aggressive disease is low. And we need to have a way to separate those two types of patients. Well, the patient was uncomfortable and on his own came to us for an MR. So now you've already seen a case, you're going to be good at this. This looks different than the other case. This is that standard sequence. You can see something looks different. A very, very dark area, nodular, mass-like area in the prostate gland. Black is, you can just black in this ADC map, which is showing us there's very restricted diffusion. There's very compact cellular density in that area. This is that perfusion, the DC map. The blue is the rest of the prostate, and boom, that area is very, very vascular. What's happening is that the contrast is enhancing very early and it's washing out really early, and that has to do with the angiogenesis of neoangiogenesis, or new blood vessels that form with cancers, and I'll discuss that a little more later. So then he went to targeted biopsy. We did a targeted biopsy with the MRI. I'll show you that later on. This is not a 3+3 cancer. This is a higher grade. This is a 4+3 cancer. So on the one hand, he was going to go to radical prostatectomy, then he was going to think about active surveillance. You get a picture of it like you do with every other cancer. There's not, every other solid organ other than prostate cancer, it is routine to get imaging before you start making treatment decisions. Prostate cancer is the only one where that still is not the case, and it's not the way it should be. So,
what color is the cancer in that picture?
the cancer is red and green, red and green. And this is just, what I call this montage. This is, I take about 4,000 images. Each case is about 4,000 images. I figure everything out, and then I, pick the ones that tell the story, and so that the doctor can see it and then show the patient instead of, don't have to bother with the 4,000 images. A little bit about why I got into this. I am a neuroradiologist, which means my specialty is brain, spine, head and neck stuff. I was always interested in neurology. I almost went into it in medical school. I was going to tell a joke. My wife told me not to, so maybe afterwards I'll tell you the joke. But this is my father, and this is my son when he was about 1, my older boy. So my father, about 15 years ago, had an elevated PSA. So he was probably about 70 years old. Elevated PSA, blah, 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 ends up getting a biopsy, a blind biopsy. And it comes back Gleason 2+5, which tells you it was before they did the new Gleason grading score. Anyway, it was, and he ended up having radiation, external beam radiation, and knock on wood, he's doing great. But the question is, did he really need treatment? He had minor morbidity. He had, some with the treatment, nothing bad. But with this active surveillance, this new understanding that these low-grade, low-volume cancers are not going to be a problem. He probably should have, or probably would have now been at least given the option to go on active surveillance. But he's doing well, so I'm happy for that. Alternatively, this is the chairman of my radiology program, and he's a blessed memory. He passed away, Gary Glazer, wonderful guy, and he developed prostate cancer in his 50, when he was about 50, and unfortunately had extraordinarily aggressive disease, and lived for about 10 years and died about 60 years old. So what we want to do is figure out the difference. We want to be able to figure out who's going to have an aggressive cancer that needs to be treated, and who has a cancer that doesn't have to be treated, because you don't want to treat somebody and give them a morbidity, give them the problems of peeing or the other problems you get if they don't need it. And the question is, can imaging of the prostate help in the setting? I hope you'll agree that it can. The reason I bring this slide up is the big difference between the incidence of prostate cancer and the mortality, people dying from prostate cancer. You all probably know that essentially everybody will get prostate cancer. If you look on autopsy studies of men in their 80s, 80% of them harbor prostate cancer in their prostate. It didn't kill them, it didn't cause a problem, but it's there. 90% of guys do. It's just something that happens. But everybody that gets prostate cancer, again, it's a very small percentage that have the aggressive type of disease. That's what I wanted to point out there. What's the most common cause of death in men with prostate cancer? Cardiovascular disease, far and away. So, watch your heart, take your aspirin, make sure your cholesterol is not too high, because that's more dangerous than the prostate cancer. This is just to point out the difference in everybody loves breast cancer, and what about prostate cancer? I mean, every other day there's some breast cancer fundraiser, and I'm all for the women and everything, but we're so far behind. It's not even funny, and this doesn't even include this is just federal aid. This doesn't include the Susan Komen, all the private philanthropy that floods into breast cancer. Whereas prostate cancer, Michael Milliken, the ADME Tech campaign you're familiar with, is one of the few really big programs that I'm aware of that's trying to raise the awareness on prostate cancer. So we're here. I got interested, thank you. I've always been interested, and then what happened is I got a new toy, and I decided I wanted to use the new toy, and I'll show you that in a second. So I went around and talked to everybody doing prostate MRI, and learned everything there is to learn, and started a program. And the key is you want to do it the right way, and I don't have an ego. I'm willing to learn. I ask guys for help. I'm building as I go, but I'm using the expertise of people who've been doing it longer. As you'll see, this is relatively new, but in Europe, this has been going on for 10 years at least. So we've kind of touched on this. Gene noted that the national panels are saying, well, gee, maybe you don't need to screen PSA so much. And if you go back to the old days before the screening era, before the PSA screening era, which started in the 80s, I think, guys didn't, as Gene said, you don't have pain. The guy would present really late in disease, and they discover the tumors, with digital rectal examination. They'd be big, bulky tumors. And oftentimes with Mets, and it is a bad deal. Well, with PSA, it's called a shift, a stage shift. So we're detecting cancers much, much earlier. The problem, though, is that we're, again, detecting cancers that are not going to cause ultimately a problem for the patients. So it's called prostate specific antigen. We should call it prostate non-specific antigen, because BPH causes PSA to go up. Prostatitis causes PSA to go up. Cancer causes PSA to go up. Everything that happens to the prostate causes PSA to go up. So just know that. When they do the trust biopsies, you've got to remember they're sampling less than 1% of the volume of the gland. I don't say this in front of urologists, but we call it poke and hope. They're just sticking it in, and maybe they'll hit something and maybe not. And then really, this getting back to this, we don't want to treat guys with whole gland therapy with the potential morbidity of whole gland treatment if they don't need it. So why not do prostate MRI? So basically, the stars have been aligning the last 10 years. I mean, you saw today technology's imperfect. I couldn't even get my presentation going, but in certain areas, it's really progressing. So what we can do with hardware and software now is light ages ahead of where we were. Where I trained at is at Stanford, and Thomas Stamey is a big prostate guy, urologist. So right before I got to Stanford, they were working with prostate MR, and realized it just didn't help. You couldn't distinguish the cancer from the normal tissue from BPH, so it didn't go anywhere. Well, now those days are over. Now we can tell. So About a year and a half ago, we got a 3T magnet, 3 Tesla magnet, named after the same guy from the car company. And that's when I said, okay, I'm gonna develop this program. But meanwhile, as I mentioned, I had to figure out how to drive it. This is Juan Fangio. If you're Formula One guys, he early era dominated racing. So it's not just good enough to have the great equipment. The hard work is figuring out how to use it the right way. Which brings us to this topic, 3T versus 1.5T. I know on the blogs and everything, 3T is great. I have 3T. I mean, I love 3T. If you have a 3T, use it. It gives you incredibly great images. But I also have 1.5T, and so does Dr. Feller down in Palm Springs, and he does exquisite work. And so does Dr. Lowe at Sharp. He is a 1.5. He does exquisite work. Of course, there's advantages for 3T, but I would, for those of us who are interested in getting this technology out to the community, I would never want to say you have to do it only on a 3T, because that's going to limit access, and the rollout of the technology. So if you put in the time to do it the right way and have the right equipment and guys that are committed, you can get beautiful studies that answer the question with 1.5T.
Excuse me, what's the difference between 3T and 1.5T, if you can explain it in layman's terms?
Yeah, good that you asked. So, I'm forever Mad Magazine, Spy versus Spy. But the T is a reflection of the strength of the magnet. So magnetic resonance imaging is taking a magnetic field and putting radio waves on it, and then getting signal from that, which brings me to this equation here, which I'll just.
Got that? Yeah.
So I'm not an engineer, but essentially the answer to the question is it's signal to noise. So anything in engineering, if you're an audiophile, you know that you want to hear that good music, but you don't want to hear the bzzz. 3T, you get much better signal to noise, and you can use that in various ways. You can use it to get the same information in much shorter time. So instead of a 7-minute scan, it might be 3-minute scan. Or you can use the same amount of time and get much more, more detailed, higher resolution pictures. That is essentially the difference. Of course, the physics of it are deeper than that, but I was a religion and history guy, not an engineer. So, but which brings me to this, though. Hopefully this will play. Is there an audio input to is this the audio input here?
Should be. Let's hope it is.
You asked the perfect question for where we were. Let's see if this works. Oops, nope. Let's go back. Well, one of the problems of having to transfer my presentation from the keynote to the PowerPoint is that the animated stuff is going to work. But I'll just tell you what this is. Did anybody ever see the movie? This is Spinal Tap. It's anybody? So it's Rob. What's his name? Reiner, who was one of his first movies. It was called a mockudrama, a rockudrama. It was a takeoff on a documentary on a rock band called Spinal Tap, and it's pretty studied. It's got Michael McKean and Christopher Guest and a few other hysterical guys. Anyway, one of the guitarists is showing Rob Reiner's character his amp, and he's telling him it's incredible because it goes to 11, and most amps only go to 10. And if they really need the extra sound, that they can crank it up to 11. And Rob Reiner's character says, okay, great, but why don't you just make 10 louder and make that the loudest it can be? Instead of having 11, this 10 would be the loudest. And the guy, he's in his, he's got his hippie hair, and he's thinking, but this goes to 11. So we go to 11 with a 3T is the answer. It would have been funnier if I could have shown the clip.
Now, are they that more expensive that you can't throw the 1.5 out and buy the 3?
Yes, they are. We are, yes. Well, for instance, the reimbursements are no different. So in other words, I have a 3T machine. It costs me a lot more money to buy it. It costs me more to run it, et cetera. And if I do a knee MRI on it, the private insurers and Medicare will pay me the same whether it was on a 1.5 or a 3T. So yeah, that's a problem. Part of learning about reading MR and imaging the prostate is understanding there's a particular type of anatomy which is reflected on the images and which was described by this guy named John McNeil, who's a pathologist that worked with Stamey at Stanford. And it turns out there's very typical zonal appearance of the prostate gland that we'll see. The other thing that's interesting about the prostate is if you look at livers or brains or kidneys, they all look the same. I mean, pretty much everybody in this room, their liver's about the same size. It's going to look about the same. The prostate gland is very interesting because every guy's is different. Every guy's gland is different in size. The normal gland is different. The cancers look different. So this is one example. And here's the BPH area called the transition zone. Here's the peripheral zone, the brighter area where most of the cancers occur. Now here's another guy. Look at the difference. This is a whopping BPH. It looks like a mosaic. You got all these little nodules of varying colors and with the capsules around them. And this guy, this little strip here is the peripheral zone. So it's being compressed by that massively enlarged central portion. The urethra runs right here. This is why BPH causes a little bit of a problem with urinary stream. So the prostate looks extraordinarily, it's got incredibly varied architecture from patient to patient, which looking at pictures all day, I found that interesting. So when we say multi-parametric, it's a fancy way of saying in the old days we just had anatomy essentially. We had tissue characteristics on T2 and T1, but it wasn't good enough, as I mentioned before. Well, now we've added functional physiologic parameters. We're looking at the kinetics of the enhancement, the way that the vasculature to the prostate, and we're looking at other physiologic parameters, such as diffusion-weighted imaging. I'll describe a little bit next few slides. MR spectroscopy, I don't do. Most of the guys in the community don't do it. It takes a long time. It's fraught with technical issues. I do MR spectroscopy routinely in the brain, and it helps sometimes. My belief in a community setting is we're not missing anything by not doing it. And in academic research settings where they're doing studies and data, it makes sense, but not for us. So here we go. So this is kind of an example of all the things together. The T2 weighted is this image here, and that gives you the exquisite anatomy. Again, this is the transition zone with BPH, which always looks like organized chaos, some people say, or a mosaic. You can see the bright signal here of the peripheral zone, something that looks different from everything else here. This is the rectum here. This is a cancer. This is the ADC, or apparent diffusion coefficient. In this sequence, black is bad. So that's the cancer there. This is the flip of the ADC. That's a high V-value image. That's bright. That's essentially the same thing as the diffusion. And here's another coded color, DCE, where the cancer is here. Now you'll notice already all of the bright signal, or the pink signal rather, or whatever called it is, in the BPH area. BPH, there's overlap. So you have to understand that when you're looking at the transitional zone, just because it's hypervascular, has early enhancement, has the kinetics that it shares with cancer, it's not cancer. And I know that because of the way it looks on the T2 weighted imaging. So that's the advantage of the multi-parametric. You put it all together and you end up having a very accurate test. So the DCE, it's based on the principle of tumor angiogenesis. And a guy named Judah Folkman was the first guy in the early 70s, I think he won a Nobel Prize in medicine, discovered that cancers, one of the problems with cancer is it's growing so fast, it outgrows its blood supply, and it can't keep up with the energy demand. So cancer cells secrete these cytokines that are cells that build up new blood vessels. And those new blood vessels, those little capillaries, provide the extra blood flow the tumor needs. And one of the characteristics of them is that they are leaky, that they don't have the same internal lining that normal blood vessels. So a cancer tumor, and in all organs for the most part, you will have early enhancement relative to normal surrounding parenchyma, and it'll wash out real fast because the contrast leaks out of those vessels. And that's what these maps, they're called kinetic maps. You're looking at the concentration change of the contrast in the gland in a dynamic manner over a 5-minute period, and we're scanning again 3,000 images. So that's the basis of the DCE. This is, I think, the same case. Yeah. So just this one is an example of how it's extending through the capsule. There's this little bit of several millimeters that shouldn't be there, and it turned out on pathologically that there was extracapsular extension. I tell you, I think that's pretty. I think that's pretty cool. So then, the restricted diffusion. Again, I talked about it. It has to do with cellular compactness. So, a cancer, is all these cells are coming together, and when it's very dense, there's this normal property of tissues called diffusion or Brownian motion. And if you have any physicists in here or engineers, Einstein described the physical property of Brownian motion and diffusion in 1906, the same year he described the theory of relativity and the photoelectric or whatever. There's three things in the same year. So what happens in water molecules will move through what will normally bounce around in tissue, and in human tissue they bounce around pretty well in the extracellular space. So the blue is the cells and the white areas are the extracellular space. So normal tissue, the water will go through pretty well. When you have very dense material, dense cellular material, there's less extracellular space, and the water molecules are restricted in their movement. So that's where the term diffusion restriction comes from. So this is a great test for looking for dense tissue, dense cancers. And I'll show you an example here. So this is another case. A guy had a PSA was up to 9.9. He'd had 2 prior trust biopsies, and they came back negative. Well, I think you know what I would do. So this is that T2 weighted image. I think my pointer's right in place. So this whole area is not good. Now notice that's very anterior. So here's the rectum. It's very anterior. Here's that diffusion map. So this black and this map, this blackness actually is related to a quantitative value. So I can put a cursor on that black area and get a number back that tells me how far the water molecules in that voxel of tissue, or the voxel meaning that the volume of tissue that we're looking at, how far those water molecules are moving. And it's just, how incredible the physics is. Normal prostate, it's about 1.4 times 10 to the minus 3 millimeters per microsecond. So if you have any mathematicians, you move it over 3 zeros, it's like 0.0013 millimeters per second. That's what normal, and normal is the brighter areas. That black level, when I put the cursor on it, comes out to about 0.600 times 10 to the minus 3. So it's 0.0006. So it's like, a micron, or I don't even know. It's tiny, but it's exquisitely demonstrated. And that was biopsied. Sorry. Sorry about that. So here's the DCE. So all these 3 parameters in this case line up. This was a high-grade cancer. It goes across midline. The reason it was missed, because it's anterior. Their throw of their needle is only 18 millimeters. So you draw a line, which is about half here. That's 18 millimeters. They're going to miss this no matter how many times they do the biopsy. He could have, this just shows that there is a direct inverse correlation between the grade of the tumor and the degree of restricted diffusion. So as the grade of the tumor goes up, you get more and more restricted diffusion. So that number goes lower and lower. And we've learned now, though, through international experience, that normal prostate, again, it's about 1,400 is what the ADC is for normal, and for prostatitis it's like 1,000 to 1,200. And people are arguing, where do you draw the line for cancer? But we're finding out that cancer, when you get below 900, it's cancer. Prostatitis doesn't do that in the peripheral zone. BPH doesn't do that. So, and these studies that, real guys in real universities in Europe, published papers demonstrating this over and over again. And this is an example. They take the histologic step sessions here, and then against the MR, and you can see, so the 3 plus 3, it's kind of dark there, and it gives you the number 1.24. So that's, then here that's a 3 plus 4 Gleason grade, and it's pretty dark, the number is 0.99. And then here, the higher grade, 4.5, and it's 0.66. So a direct correlation, and not just my subjective opinion, a number I actually generate from the magnet correlates with the tumor grade. And as we know, the Gleason grade is the most important predictor of the ultimate outcome. So the dynamic contrast enhanced technique, essentially IV injection, and we start scanning just through the prostate. We keep scanning over and over and over again over 5 minutes, and get a ton of images. And then I actually view them, to be honest with you, I view them what we call raw. So I will roll through the 2,400 images and see just my own eye. I'll pick up you can do that, pick up the early enhancing areas. I also use the fancy maps with the software to figure it out. So again, this is just another map. Again, here in the BPH, you can see the central portion of the gland, the transition zone. You can see how very vascular that non-malignant benign BPH looks. However, in the peripheral zone, that's abnormal. Prostatitis can do that too, but when I look at all the other sequences, I put it together and figure out which is which. Yes?
Quick question. Can you go back to that last slide?
Yeah.
Maybe a little bit. What exactly are the red spots and what exactly
Oh,
are the green spots?
yeah, so it's if you look at it's just a representation of the enhancement, the concentration of enhancement at a certain time point. So the algorithm would be that, and they're in arbitrary units. So if it's below 20 units at that particular time point, it's coded blue. If it's over 40, it's coded red, and if it's like 30, it's coded green. So and it would, on the raw images, you would just see this area enhancing earlier and stronger than everything else. Does that answer your question?
Yeah, red is denser than blue.
Yeah. So red means, so the way it's coded is the earlier enhancing areas and the areas with earlier washout, because this is it's putting together the wash in and wash out, are coded as red.
So does that indicate cancer because of the angiogenesis?
Yes, right, exactly.
Okay.
So yeah, the reason why it's enhancing earlier and washing out earlier fundamentally is related to that neoangiogenesis and those leaky cells.
Thank you.
You're welcome. And this is just a graphic representation. The red curve that we were just talking about, really early uptake, and it enhances like crazy, and then it washes out early. The normal prostate just slowly, increasingly enhances, and kind of the type 2 curve, a rapid uptake, but then it plateaus. And not every tumor follows the rules, and there's overlap. But that's the advantage of using all the different parameters to make your decision. I mentioned why we're not using MR spectroscopy. So again, these are studies looking at using statistics to show how good we are at picking up the tumor, and they separate into each different sequence and then putting it all together. If you're familiar with these receiver operating characteristics or area under the curve, it's kind of standard ways to evaluate a test of any kind. 0.91 is pretty darn good. I mean, it's about as good as it gets for tests. It means, it's a very accurate study. This is another way to look at it. That the key thing here, I think, is that at the very high grade cancers, we're absolutely not going to miss it. The intermediate grade, 90% is impressive. And then the low grade, we're not as good at. And the reason for that is because of what they call tumor sparse, Gleason grade 6 tumor sparse. So I mentioned about cellular density and compactness, and how that we rely on that to see that reflected in the restricted diffusion, the black signal. When you have a type of cancer where it's one cell here, then some normal stroma, then another cell here, another cancer cell, then normal stroma, another cancer cell, normal stroma, they call it tumor sparse. I don't pick that up. So that would be a criticism against MR, except if you believe the data that the low-grade, low-volume cancers are not clinically relevant. They're not going to injure the patient. They're not going to spread outside the capsule. They're not going to metastasize. And this is out of the urology literature. And we'll talk about that. So this is a key point, I think, for the whole talk. And again, this is out of the urology literature in Europe. The negative predictive value. So when my friend had his MR and I didn't see anything worrisome, I could tell him, 97% confidence that we're not missing anything. Tests don't get any better than that. I mean, it's and for the 3+4, it's 90%. That's very good. And this is being kind when we say compares favorably. I mean, it blows it out of the water. I mean, it completely blows it out of the water. Compared to the random biopsies. Again, so this is the urology literature in Europe. They've been on the bandwagon for about 10 years, even longer, and we're way behind the United States. So if you can see it, what are you going to do now? In other words, I see something suspicious on the MR. What now? Well, you got to be able to get at it. So I was really proud of myself. I did this myself, this slide. So just a cartoon of what happens with the truss biopsies. you completely miss the lesion, you happen to pick up a non-important cancer, and that has to do with the index lesion, which means it's now generally accepted that the largest, highest grade cancer is the one that's going to cause the problem. Or this one, you undergrade, you kind of skim along and you don't really get the full thing. As opposed to MR guidance. So, using a military aphorism, ultrasound is like carpet bombing, and, you might kill the bad guys once in a while, but you also kill a lot of other people. And whereas with MR guided, it's a laser, boom. This is actually a case. So this is the needle guide with the fiducial market, and this is the course of the biopsy, sticking right into the one area of concern. Why not do it that way? And now this is actually, that's the same picture. So this is what the device looks like. They call this the Dynatrim, the transrectal end magnet biopsy system. So this is the needle guide. You put a needle through the needle guide. This whole contraption attaches to the table. When I first, oops. So the blue man is actually, at first I thought it looked like he was laying on his back, but he's laying on his stomach, and these are the buttocks here. So he's laying on his stomach. The needle guide goes in. This is attached to the table. Then, by the way, this is all, the way we do it is, I've never yet done a consecutive diagnostic study and biopsy one day. Most people are not doing it that way unless there's a special thing, somebody flies from out of the country or out of state. I think Dr. Feller once in a blue moon does them, but I generally will do the diagnostic study, discuss it with the doctor and the patient, and then schedule the patient to come back. So when they come back, we position the patient, which takes, the entire study takes about 25 to 30 minutes. About 90% of the time is getting everything lined up right. So once everything's lined up right, the device has these 3 knobs, and it's 3 degrees of freedom, which alters the trajectory of the needle guide. So it goes up, down, right, left, and it changes the angle. So I do a quick 30-second scan to localize the prostate, and then knowing my landmarks from having the diagnostic study, I just literally drop a target on the lesion, and then the computer software tells me the coordinates, and I just dial them. I then just turn the knobs the right way. Then I do a localizing scan. So this is the green is the fiducial. That's the way the computer knows where in space the needle guide is. And then I have to put the X on there, then I make the adjustments, and it shows you the exact trajectory. And it tells me which length of needle I need. They're always 18 gauge, the same that is used for transrectal ultrasound guided. And boom, I confirm it, and you do the biopsy. This has all been validated out of Europe. Multiple studies in the last 5 years, comparing it every which way to the other types of biopsies, and it's no surprise it blows it up, blows it out of the water. So the MR biopsy is blue, and red is 2 times, green is 3 times trust biopsy, and you can see, of course, it's going to be. We can actually see the tumor. Of course, we're going to hit it. Versus just the poke and hope. Again, this is just more literature supporting it. This comes into discussion about, you may have heard of the fusion, ultrasound fusion with MR type of biopsy. Has anybody heard of that? So I can do the MR and I can see the lesion and I can biopsy it with MR. Okay. Well, industry, the vendors have created a system which is not cheap, and it's not exactly perfect because the ultrasound physics is not the same as the MR physics, but if you use this special equipment, software and hardware, you can take the data from the MR, load it into the ultrasound machine that's designed for this type of thing, and then when the urologist is scanning with the ultrasound, he'll see the MR overlaid those images, which is watch what I say here, but that's a kind of a cumbersome, expensive way for the biopsies to stay with urologists. You know, yes, they can do it that way, but it's a lot of extra effort. Anyway, that's that. So this just shows that when you're targeting the lesion, you're not going to undergrade because you're seeing the largest tumor. You're seeing as opposed to the random where you undergrade. From the random biopsy, you undergrade a significant, almost 50% of the time. So if you look at any cancer hard enough, breast cancer, any cancer, and you do histologic sections, you will find tiny other foci of cancer. Prostate gland, we know that because it's a small gland and they oftentimes do that, whereas they don't routinely do that with other tumors. So one of the arguments is like, well, if you do targeted biopsy and then targeted therapy, which is, of course, the huge topic next beyond this, you've got to discuss, well, what about the tiny little cancers you don't know about? And that comes to the concept of the index lesion. And this has been this notion has been discussed for 30 years, including by Stamey, including by the people in the breast community, which is the notion that there is an index lesion that is it's going to be the cause that's going to cause the problem. It's going to be a lesion that's bigger than a certain size. It's going to be a lesion with a certain grade, and that's the one you need to treat. And if somebody happens to have a foci of 3+3 or PIN somewhere else, that's not going to be the problem. Yeah, so I just... This was an interesting study out of Nature in 2009 where they took a large series of prostate cancer patients who had extensive metastatic disease, and they did a genomic analysis on almost every single metastatic lesion. And 95% of the lesions came from this one cancer line. So in other words, it was one index lesion that accounted for the entire metastatic spread. So again, it's more evidence that there's one bad guy, and that's the one you got to figure out. So one of the things that was a bit discussed with the new technology is, well, how do we know we're doing it right? What are the right sequences to do, and how do we report it? And in the last 3 or 4 years, the radiologists in Europe and in America have gotten together and came up with a standard way to do the studies and a standard way to report the studies. And we've already looked at the different sequences, and we talked about how the peripheral zone looks different than the transition zone. And you have to understand that and read them differently. Transition zone is going to have all of the BPH, which BPH, the stromal nodules, which are benign adenomas, they have very compact cellular density, and they look dark on those diffusion images. They have restricted diffusion. So we've learned that we dismiss the diffusion sequence in the peripheral zone, in the transition zone, and we rely on the architecture and the T2-weighted images. The reverse is true in the peripheral zone. In the peripheral zone, diffusion weighted is king. And so this has all been worked out, and any guy that's interested in prostate MR knows this and uses this system. it's a 1 to 5 score. 1 is nothing, and 5 is it's as bad as it can be. So, so this is another prostate. This is a normal peripheral zone, homogeneously bright on T2. This is more like my friend had, the little striated areas of T2. That's considered benign and likely related to prior prostatitis or current prostatitis. Yes, same thing. This is another example similar to my friend, just kind of diffuse bilateral, linear striated wedge-shaped areas of dark signal. Same. Oh, this is important. This is another thing we learned. The central zone of the gland is up at the base, and it's where the ejaculatory ducts run, and it is very, very dark on T2, and also cellular compactness, so it looks bright on diffusion or low signal ADC map. So that's something you have to learn. It's a pitfall when you first start doing it. And moving to then, what does the cancer look like? Focal, nodular, dark mass. The pyroid's 5. It means it's larger than 1.5, or it's extending outside the capsule. And same kind of thing for, there's a specific way to look at these in the transition zone. So the point is, we've come a long way. It's not willy-nilly. There is a standardized way of doing the studies and a standardized way of reporting them, so that when I send my report to Dr. Walzer, who, and he's going to, he knows what I'm talking about. He gets the images he wants and needs if he's going to do his target therapy.
How long does it take to do the test?
It's about 30 minutes.
And you could do all those images in 30 minutes? Wow.
Yep. This is how ultimately you score it. I don't think you need to know that. Beautiful images. Confirmed. T3 means extending outside the capsule. And this is actually, this is not my slide, I ripped it off. But so you can see the incredible correlation. So the capsule's kind of compressed zone here, and you can see the tumor extending out and how it correlates with MR. There's a little bit of tumor popping out. Why wouldn't you want to get a picture like that? I don't know. Same thing. The take-home message is MR can see the tumor. Trust Mrs. Tumor, it can't see it. You're sampling less than 1% of the volume when you do a trust biopsy. We don't undergrade it because we see the index lesion. We see the area. If it doesn't pop out in MRI, it's almost never going to be a high-grade lesion. So this is the next key thing about all this is if you can see cancer in the prostate gland with MR, and then you can do targeted therapy. And this is extraordinarily exciting. Dr. Feller in Palm Springs is on an NIH trial using the laser thermal energy. And I've been there while I treated cases. So I've shown you the images. Just like I do the biopsy, he's instead of a needle in there, he's got a laser probe. And you can watch as the tumor, it shows you a color map of the heat and how the heat's being sumped away by the veins. There's a lot of very prominent venous plexus around the prostate gland. So you can monitor exactly the temperature within the tumor, within the surrounding structures, and it disappears. And then, the follow-up studies, I think I forgot to put a follow-up study in. The tumor's there, and then it's gone. So it has to be validated, it's undergoing validation by the NIH. Anytime you introduce a new treatment, you need time to see what the outcomes are. but it's pretty cool. Is MRI the GPS for detecting and localizing prostate cancer and potentially treating prostate cancer? I say it is, and I say we have it right here in San Diego. I'll just share with you one. This is the urology community is reluctant. Okay, a year or so ago there was in this country, not so in Europe, there was a point counterpoint article in the Journal of Urology, and the pro was Daniel Marks out of UCLA, I think, and the negative was a guy from Yale, and he pointed out, well, we don't know this and we don't know that, and they're hesitant, but this is getting back to being your own advocate, and to sum it all up. I found this on a blog. I go into blogs because, I want to know what you guys are thinking and stuff. And one of the things I found is there's a lot of people think it has to be 3T or it has to be endorectal coil. I forgot to mention, we don't use endorectal coil. Very important point. You don't have anything in your tuchus while you're getting the study done. You just lay there. Another reason why I got interested, because the endorectal coil is not an easy thing for anybody.
Do you have to be put out?
No. For the diagnostic, you just come in and for the biopsy, I do offer and suggest some mild sedation, so everybody thinks I did a good job when they're happy with me at the end. So this was on a blog. You can read it. The trick will, the trick will be combining the very real need to accumulate data that justifies the appropriate use of this technology with training and education that ensures its use in the best interests of patients, as opposed to economic interests of physicians and hospitals and equipment manufacturers. So my point is that, it's going to pan out, I think, because it's not coming. Oftentimes in medicine or anything else, you have a new technology and it's added on. It doesn't replace anything, it just adds on and makes things. This has the potential to, I do have one more thing, speaking of. So this is the last thing I'll show you. This is part of a report, and it shows you this is how I do my reports. I don't read anything until I have all the information from the doctors. So the guy's 79, his PSA's 39. He's had 5 prior trust biopsy sessions. 5. Add up the number of needles, that is. All benign. So I always put a value for prostate cancer, a value for potential MRI-guided biopsy. So now you're all experts. Something doesn't look right here. Nothing looks right here on this sequence. It's all too dark. I don't see the normal zonal differentiation that you usually get. Then on my ADC, black is bad. Black, 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 and it's anterior, and it's wrapping run left. Why did they not get it after 500 needles? Because they can't get it. It's anterior. This is just one snapshot from the raw image of those 2400 dynamic sequence. So even just without the fancy color maps, you can see that whole area is early enhancing. That is all tumor. We did a biopsy. This is my case. And then unfortunately came back 4 + 4, and then he's got Mets. So the poor guy, it took a while to get his PSA to 39, right? I mean, those 5 trust biopsies were over years, and then you have a way to look at it. And I would only have to say it's a perfect technology, and we're getting better, but why not utilize it? All right, thank you very much for listening. I'll be happy to answer any questions.
Before we get too started, I'll ask the first question is, how in the heck do we get to you?
Imaging healthcare specialist, I will provide you with my cell phone number. I talk to patients all the time. I'm happy to talk to patients. I go over cases with patients. I show them the images if they want to show. I'm very passionate about this. So, Imaging Healthcare Specialists is the website. I'll give Gene my cell phone if you want to talk to him directly.
But the issue is deeper than that, and that is an insurable issue.
Insurance.
Okay, well, I'll tell you, here's a couple things. A, there's not one insurance that we don't take. B, our company has a cash menu. I can tell you right now that you can come in and get the study. Anyone want to guess what it costs? Come on, guess.
2,500.
Another guess. One more guess.
1,500.
$575. $575. You can't afford not to get it. No, that's the cost. I mean, it's not an easy test for me to read. It takes a long time, but that's what we charge.
We need a referral?
We have to have a doctor's referral.
What kind of doctor?
Any doctor. It can be a chiropractor. It can be, I'm not kidding. It's national law. Federal law. I mean, California
That's
law.
extremely important to know, because that's the issue that our people have been running
Where is
into
your office?
forever.
The office where I do where I do the diagnostic studies is in the UTC, next to Scripps Memorial Hospital. It's actually not too far.
In San Diego.
Oh, yeah.
What's the address?
It's Regents Row. You know the Starbucks and Einstein's over there?
Yeah.
It's right in the back there.
Oh, it's in that building?
What's that?
In that building?
Yeah, it's 4150, I think. Is that what? is that
Jane,
Yeah,
Jane, would you run that, the latest controversy by him that we got last week about referrals? Urologists are gonna refuse to give us referrals?
I don't know what you're
Wasn't that what Dennis Walker said?
Yes.
I don't
Well,
remember enough
Chuck
of it
was
to tell.
involved in it.
Yeah, I'd love to hear it.
I'd like to have you
Well-
explain that some.
One of our members was trying to go to the desert to get the imaging.
Could you use a microphone so we can all hear?
Try to, the only one we've got working so far.
Go up there, talk through here.
Let me talk first. Well, one of our members was trying to get down to the desert to get the MP-MRI. And he went to
Oh, I know the case. I heard it.
two different urologists, and they both refused to give him a referral. So,
I think that was an isolated event, though. I don't know if that's uniform. I haven't heard that myself, but it's
yeah.
uniform.
But I'm sure our good doctor here could, if you're having trouble getting to him, he could refer you to a doctor that would give a referral.
That's true.
Would you say that, Doctor, that it's not true that the Urological Association is petitioning the government and the AMA to let them be in charge of prostate cancer? I mean, that's the story that's going around.
Well, I kind of alluded to it earlier. I don't know that there's any.
Repeat the question, please.
Lyle said, is it true that the urologic community is trying to petition whatever body to make sure they remain in charge of prostate cancer? Is that pretty much what you said?
We, in fact, had some private conversations with a group that I won't name that said the same thing, that they're going to be in charge of prostate cancer.
Well,
And they won't have anything, they don't even have any oncologists in their group.
Well, it gets back to the, you know, there's a saying in medicine, today's dogma is tomorrow's dog doo-doo. I mean, it's been very dogmatic how things have been done. And this is what they call disruptive technology. This changes how it's done. And you know, I think it was T.S. Eliot once said it's very hard to get somebody to change their opinion of something when their livelihood depends on them believing a certain way. I think, but ultimately they won't be successful in the sense that patients will be come informed. There are plenty of urologists who are supportive of this technology. I get referrals from lots of urologists, including from a certain group. Yeah, not from all of them, but I can't imagine that they're gonna be reluctant. They're gonna be reluctant, and so it's gonna have to be guys like me that go out and just say, this is what's happening. It's available. Here's the data. The data is it's not radiology data. It's from the urology community, from their journals, and from doctors who put patients first.
The take-home message is we have to find the right way to access him, and we'll do our best to find all the information to help you do that. So, yeah, Ron, go ahead.
Could you tell us about the usefulness of MRI for recurrent prostate cancer after surgery, after radiation therapy?
Yeah, obviously we just kind of scratched the, just the surface here on this type of talk. But so one of the problems, yes, if you have a whole gland therapy and you have what they call biochemical recurrence, which is, happens. Traditionally, there's, we didn't know what to do. You did a CT, you did a PET scan or whatever. MR is currently the best way for finding local recurrent disease. Particularly for that, it's the DCE sequence is very, very good for finding a real hyper-enhancing lesion. It's not perfect. We often don't find it because oftentimes it isn't a local recurrence. It's some scattered mats we can't pick up. So yeah, for radiation therapy, we do it routinely. When they do their planning, they will want to know where the dominant intraprostatic lesion is. So they'll get the MR and they'll design their radiation treatment with an extra boost to the X to where the actual tumor is, and they'll model it that way. So yes, it's useful absolutely in those settings.
Go ahead, follow that.
What you just said, what we have learned over the last couple of years is that Dr. Almeida, who was very close to our group, is using a C11 CT PET scan using acetate for injected acetate for doing CT PET scans. So could you compare that to your situation?
Well, what you described is the best method for finding metastatic disease. The MR still is better for finding the local recurrence because the resolution of the PET CT, even with a great agent, will find tiny metastases. You can't see well enough in the post-prostatectomy bed. So they're complementary because you could say first you could do the MRI, and if you don't find recurrent disease in the MRI, then you go to the PET CT to look for widespread mets.
Speak really loud. Okay. Your hand is backwards.
Okay. Thank you. We heard about the parameter, multi-parameter MRI guided biopsy years ago, several years ago at least. How different are you talking about the same thing as that came out a few years ago, or your procedures are new?
Yeah, well, we go to 11. No, just kidding. No, it's this. This has been out for a few years. It's the same MR guided type of biopsy. Yes, no different. Yes, sir.
I had a CT guided image biopsy at Imaging Healthcare for a metastatic prostate cancer. And that right now appears to be the bellwether mass that is guiding subsequent treatment. What advantage over the CT guided needle biopsy would the multi-parametric MRI have provided to me on this same mass?
So you're talking about a metastatic lesion?
Yes.
Where was it?
It's in the seminal vesicle area.
Right. If I imagine that it must have been, the answer is most of the time, if it's a bulky lesion, you can see with CT, there's really, Well, they must have picked it up. Did they pick up with CT?
Yes, and then
Okay.
proceeded to then biopsy
Okay.
with the guided needle.
Well, most of the time, for particularly intraprostatic tumors, there's no way CT can distinguish a tumor from the surrounding prostate. So in your case, it sounds like it was obviously a seminal vesicle. It was a new abnormality. It looked different, and they could see it with CT. So there'd be no benefit for me to do it by MRI. The value for MRI is when you can't see it any other way. That's when you use MR.
Would you possibly pick that up with your MRI?
Of course, there's, yeah, we were exquisitely picked up, absolutely.
Yes. My question is there a time coming when the MRI itself can diagnose and we will not even have to follow up with a biopsy? Is that envisioned?
I don't, there's a guy named Ronald Wheeler, I don't know if you've ever heard of him, urologist out of Florida, and he wrote a book. I happened to meet him. He sent a patient. He wrote a book called Men at Risk. It's kind of, he's way out there. The reason I bring it up is he believes that we should obviate biopsies. He believes that we should go directly to treatment. I personally don't think that will happen because no test is perfect. I mean, there's still some overlap. If you talk to any oncologist, and I have lots of oncologist friends, they do not like to treat something without knowing for a fact, seeing it under the microscope what it is. So I don't foresee that happening.
Can we take anything on the side of your questions?
Yeah, I had a radical prostatectomy with positive margins. And they wanted to just go in and do a radiation after the surgery. And I insisted on getting an MRI. And I'm wondering, is that reasonable? That would MRI provide guidance for radiation treatment in that case?
I think, first of all, so they found on the pathologic specimen, they found that it extended beyond the margins, right?
They had the positive margins around the bladder.
Yeah. The only advantage of MR in that case, and it is utilized, is again to tailor exactly the type of treatment plan they're going to give for you. So instead of doing a carpet bombing radiation treatment, if I can show them an MR exactly where what looks to be recurrent or residual disease is, then they can tailor their treatment to that, so it would be of value in that point. However, if I did the study and I didn't see anything, you still have to be treated. Yes, sir.
How does color Doppler technology compare with MRI?
So, a guy named, you've heard the name, Duke Bond. I will say nobody's been able to reproduce what he does, is the simplest way to say it. So, I rely on papers and other people doing it. I'm not a trailblazer. I just say that nobody else can reproduce what he does. So that's all I can say. Yes, sir.
This is going to be a lot simpler question. You're talking about recurrence, and is just the pure fact of having an advancing PSA after the surgery and after the radiation, is that recurrence? Is that what you're talking about by recurrence?
Well, that would, after radiation treatment, you sometimes get a little bump in PSA, but in general, at a certain point, it's considered a biochemical recurrence, whether you can find tumor anywhere or not. That's my understanding, yes.
Okay, we have time for one more question, center section.
Can you do an MRI on a patient with a pacemaker?
The answer is you can do it, but we may not do it. Meaning, it's a guy named Rob Russo, a cardiologist at Scripps, who's subsequently left, had a program, and it's a very detailed way you have to do it. You have to have the pacemaker manufacturer vendor there who can turn the dials on and off and then reset it. And you have to have a certain accreditation because there is going to be some current going through the wires. It can be done. We have looked into it, and we are not offering it because it's a little beyond our scope of practice.
Okay, thank you, Priscilla.